Apologize for the delay. We had a meeting that the administration was conducting, and even though they know that a bunch of us were in have classes, they still needed to finish their agenda, so I apologize for that. I'm going to turn on the lecture capture. Okay, we're going to start on page 195. We're going to deal with pre and post-op care today and roll into the gallbladder care on Thursday. As I mentioned real quickly a while ago, I am very sick today. I'm having trouble catching my breath, so I've got not chronic bronchitis, but acute bronchitis. So apologize if I sound deep and raspy. I'm not going through puberty a second time. So, but I am here for the count. All right. So I'm going to switch us over to the computer, and then is there any questions anybody have from the readings or the prep work that you want to address before we get started? Yes, the question the students asked me was about the prep work. I went out yesterday and checked the prep work, and they are all there and they're all intact. So if you're not able to hear it, it has to do something with the buffer on your computer. So I spent 2 hours and watched all 4 of those prep work, and as well as the kernel, and they are fully there. So, okay, so I did notice something that I had never noticed before. There are 2 ways to play the video. If you click on the picture, it may not play all of it because it'll only download a portion at a time. If you click on the download line, the URL at the bottom, which is the way I did it, it plays the entire thing from start to finish. Okay? All right, thank you for reminding me of that. Okay, so let's cover a few quick definitions. I've got most of them written there. It's going to sound like I'm rushing through things just because I have to force my breath to be able for you to hear me. But even though I may sound sober or somber or whatever the right word for it is, this is still going to be hopefully a pleasant time for you. All right, so recognize that surgery by definition is any procedure done to alter tissue or organ integrity. It can be accomplished in multiple locations, and it can be for multiple purposes. And out on the pre-class prep work, we talked about some of those different types of purposes. When we talk about the perioperative period, it's that point in a person's life that encompasses a surgical procedure. It's primarily divided into 3 periods of time. The preoperative period, which is simply the time before the surgery, that includes all the events leading up to a specific procedure being done. So that includes the time at the clinic, when the person went to the primary provider. That includes the referral to the surgeon, etc. Intraoperative is the time during the surgery itself. We're not specifically addressing intraoperative during this lecture, but for those of you who want to read it during your summertime this summer, it's specialty nursing, if you will. And chapter 15, I believe, in your Iggy book covers that intraoperative period. Postoperative is the time following a surgery. That includes the time in the post-anesthesia care unit or the PACU unit. It also includes the time if they're admitted to the hospital or the time when they are recuperating at home or in a nursing home or a rehab facility. The last definition on that page is the Surgical Care Improvement Project, the SCIP project. These are mandated by the government, by the Medicare and Medicaid, mandate these core measures to be used as a minimal level of standard of care for patients receiving surgeries to minimize those risks. So if you look at page 231, table 14.1, it lists the common ones that we focus on at this point in time. The SCIP project used to include many more, but over several years they become such a part of standard of care that they're no longer even listed. But you'll notice that the vast majority of them deal primarily with infection, pre-op medication, and DVT prophylaxis. You do need to have a grasp of what that SCIP project means to you as a nurse, because you will be held to that standard as you practice on a post-op floor. All right. So out on the pre-class pep work, we talked about how surgeries can be classified in multiple ways. I explained how each of these are a little bit different. The main thing that I want you to focus on as far as understanding the compare and contrast part is what's different between a major and a minor procedure. Most of the others are pretty self-explanatory, and when you see the prep work, you'll see that they are. And just as I mentioned in the prep work, it doesn't matter how surgery is classified. It represents a major life event, a major life stressor for all clients. For just a moment, I want to focus on, you were supposed to ask 3 people who've had surgery, who is the one person that you could remember the most and why? And so, Tonkwall, tell us somebody that you discovered.
I asked, actually, my 9-year-old daughter.
Okay.
And she said that she remembers the old man that put the mask on her before she fell asleep.
Okay, so the
Didn't know
anesthetist.
what that was called, obviously.
Okay.
And so I told her and I asked her why, and she said because he was really fun.
Okay. How about somebody else in Tonkwall? Okay, let's shift to Enid. How about Enid?
My husband remembers his pre-op nurse, or his perioperative nurse, because
Okay.
he was scared to death. And she made
Oh.
him feel comfortable.
Very good. Anybody else in Enid?
My sister actually said that her nurse didn't really know what's going on because her situation was an emergency. And so her doctor was the one so when the doctor finally came in, she kind of calmed her down.
Okay. And how about Stillwater?
That's my sister, and she said she remembered the nurses post-op the most because they were yelling at her, so I guess she pulled her IV out.
Okay. Anybody else in Stillwater? Well, typically when I have students do this exercise, by and large, about 80% it will be the nurse that the person will remember, whether it's pre-op or post-op, or the nurse that took care of them, and the circulating nurse before they went under anesthesia. Okay, so we play a vital role in minimizing the stress of this event by not only the care we provide, but the compassion we provide as well. All right. Let's switch back to our computer here. All right, this slide, I mentioned before, this is a summary slide, meaning that each of those 9 categories represent a portion of the pre-op assessment. So they're covered in the following slides. So as we go through them, these are the things that I put it all in one slide so you can see it all in one place. History of present illness. The history of present illness is simply the course of events and signs and symptoms that was occurring with that client that necessitated surgery needs to occur. We used to call it a chief complaint, and then people misunderstood what we were talking about. They thought that they thought that we were criticizing them for their concerns. The next one is the medical history. So medical history includes two main things. Not 2, I'm sorry, about 7 main things. The first one has to do with previous surgeries and anesthesia. And that includes their direct family members.
Mr. Barrett, do you have your student mic on?
I do, thank you. So this previous surgeries and anesthesia, we're trying to identify if the patient or someone related to them by blood, a parent or a brother or sister, has ever had an untoward or an adverse reaction to anesthesia. And back in the fall, we talked about one of those types of reactions. What was it? Do you remember?
malignant hyperthermia.
Excellent, malignant hyperthermia. And so part of our screening process is we want to know if a client has had that or a family member, because it increases the possibility of them having it again because of a previous reaction. The next part of that medical history is our acronym that focuses on those serious illnesses or trauma. So the first one being allergies. We want to know if they're allergic to latex, because so much of what we use in the hospital environment includes latex. We want to know their medicines, including herbal meds that they might be allergic to. We want to know if they're allergic to iodine or betadine. We want to even know if they're allergic to, I'm so sorry, give me just a second here. To food stuff. Okay, so sometimes a client can be allergic to bananas or avocados and actually have a similar allergy to latex when they're encountering latex. Okay. Letter B stands for bleeding tendencies, or if the client is taking meds that affect their tendency to bleed during that post-op or perioperative time. So Enid, what are the two drug classes we're looking for?
Anticoagulants.
That's one.
Blood thinners.
Blood thinners.
They said anticoagulants and NSAID.
Anticoagulants, and NSAID is an example of the other category, but it's the antiplatelet aggregator agents. Okay, so NSAIDs are an example of that. Aspirin is another example. And then we have drugs like Plavix or clopidogrel that is part of that. So when we're assessing their risk for bleeding, we're looking at those kinds of things. It would also include things like if they have hemophilia or some type of blood dyscrasia, blood disease that makes it where they have a tendency to bleed. And then one more, Stillwater, that we just talked about in Mrs. Martinez's lecture recently that might affect their bleeding potential. Pardon?
Fish oil.
Fish oil, not as much as the one I'm thinking about. There's one that's a higher priority to that. Alcohol. Any person who has consumed enough alcohol and damaged their liver will often have damaged their liver's ability to produce the clotting factors. Okay. C stands for cortisone or steroid use. So again, like our COPD patients who take a daily prednisone, we'd want to know that ahead of time because of the risks that it poses for them. D for diabetes, specifically diabetes mellitus. You'll discover in adult too, there are other forms of diabetes, but that's the one you've learned about so far because of the risk for a blood sugar problem, either hypo or hyper. And E is emboli. Emboli meaning anything where the client has experienced a clot at some point in time. So a DVT, an MI, a CVA, any of those would be examples of that, especially if it's occurred in the last 6 months. The third part of that medical history is their use of alcohol, nicotine, and recreational drugs. And we talked about this a little bit before, but I want to focus on some specific risks in the context of surgery. First off, there's a risk for withdrawal signs and symptoms. So the client, sorry, I thought I had those listed for you. I guess you'll just have to write them in yourself for that. Okay, so first off, there's a risk for withdrawal if they are a heavy user. And that withdrawal, remember, depending on the nature of the drug, will typically be the opposite of its pleasurable effect. So if it's a stimulant, they'll have a depressant effect. If it's a depressant, they'll have a stimulant effect and may experience delirium as a result of that withdrawal. As little as 2 drinks of alcohol a day can cause withdrawal signs and symptoms during the perioperative period. And oftentimes, clients who focus on these addictions often have malnutrition that will interfere with their ability to recover. And lastly, they have an unpredictable response to anesthesia. Our liver is very efficient, and so the more it's exposed to a substance, the more efficient it becomes in processing or breaking that substance down, metabolizing that. And it does it through a process we call enzyme induction. When a person has a chronic alcohol problem and they have enzyme induction, they may actually require more anesthesia than a person of their height and weight. in order to meet their need. So it can interfere with their ability to be anesthetized. Nicotine leads to a hypercoagulability and can lead to polycythemia, which increases their risk for a thrombus or a DVT in that perioperative period. So it makes the blood thicker because of that polycythemia. So not so much the nicotine as much as the carbon monoxide that they inhale from the tobacco. Nicotine decreases the available hemoglobin, or the carbon monoxide decreases available hemoglobin for oxygen transport, so tissues that have been surgically incised may not get the oxygen and nutrition they need effectively to heal. Obviously, we talked about their lung tissue itself could be damaged, so their gas exchange could be impaired. And then lastly, nicotine is a potent vasoconstrictor, meaning that it affects the ability for the smaller vessels to receive a blood supply. And then even caffeine, the absence of caffeine can cause severe headaches during that withdrawal time. So somebody who's a heavy coffee drinker or a heavy tea or cola drinker may experience severe headaches, and the post-op nurse may mistaken that for a CVA symptom. The fourth thing on that medical history is medications. Remember, with medications, we're talking about prescription, over-the-counter meds, we're talking about prescription, over-the-counter, and even herbals. We talked before about how that sometimes patients don't consider herbal supplements as medications, but they have the similar effect on the body as a medication. So as a healthcare team, we do consider them something we need to ask about. And we'll talk specifically about some of them later in the lecture. And then we need to know, the perioperative team needs to know when the last doses of those medications were given. Now, there are some meds that we call vital meds, those meds that pertain to the cardiovascular system, so in other words, to their heart muscle itself, or to hypertension, or to anti-seizure meds, and typically steroids. Those four will often be continued with a sip of water even during the pre-op time, but that needs to be clarified with the surgeon and anesthetist. The fifth part of that is chronic illnesses. Remember, there are some illnesses that can affect the positioning of the patient during surgery. So arthritis, for example, even though the patient may be relaxed, if you will, because of anesthesia, they're going to feel the pain and discomfort when they're no longer under it, if we put them in a position that their body is not comfortable with. And there are chronic illnesses like fibromyalgia that can affect pain levels during the post-op time, making it difficult to get that person comfortable. And lastly, those chronic illnesses like renal failure or heart failure may influence the outcome of the procedure based on the fact that they're interfering with fluid electrolyte balances as well. The next one is psychological illnesses. So we talked a little bit about this with the dementias, and we talked about schizophrenia earlier in the semester. Remember that some illnesses like schizophrenia, those that have cognitive impairment, affect the person's perceptions. So they may actually be paranoid of you as the nurse or you as the healthcare team. And they may influence, if they have a dementia, they may influence the teaching and learning that you're able to do with them, as well as their anxiety level during that time. And I mentioned the dementias there as well. Cultural beliefs and practices becomes the next step or the next level on that assessment. Remember that clients can have rituals, candles, herbs, healers that they do that provides them comfort and hope. And they often have a part of their culture determines who makes decisions within the family group. So is it the individual themselves, or is it the oldest female, or is it the oldest male, or is it the husband, or who is it that makes those decisions? And then lastly, when it comes to some Native American tribes, if you have to amputate, the tribe wants part of that body part for burial, so that when that patient dies, they can be reunited in the afterlife. And then, even though some of the top part deals with spiritual things in some respect, I've separated those because sometimes people see those as differently. Culture and spiritual are so overlapping that they often are confusing for us to separate. but many times they have specific prayer rituals or spiritual leaders they want, and we need to reach out to them for it, those people if we can. And then recognize some of them have belief systems that will alter the kind of care that they would consent to. And I've given you the example of Jehovah's Witnesses and their opposal of blood transfusions. Next one deals with social assessment. In other words, who does this person have to support, especially if there's going to be a recovery time? Is there someone who is cognitive and physically able to provide them the care that they need during that recovery time? And do they have the financial resources for the equipment that they might need during that recovery time as well? So again, during our social assessment, it might necessitate sending them a social worker during that perioperative time to help them make arrangements. And then cognitive assessment. So recognize we need to know what their mental capability is so that we can distinguish their baseline from any delirium that might occur during the post-op period. And that includes their ability to read, write, or speak the nurse's language. So if there's a cultural barrier or a communication barrier, that needs to be documented so that we can use the language line. The language line is a phone that many hospitals use that allows, it has two phone receivers. And so the patient picks up one, the nurse picks up the other, and the person on the other end of the line is able to listen to each of the individuals, translate and communicate it to the other person. And so many of the small and rural hospitals will use a language line. Other hospitals will use an actual translator in-house. Stillwater, should a healthcare team use a family member as a translator when it comes to informed consent or the perioperative period? Okay, and why? It could be biased, okay. What else?
Privacy.
Privacy would be another one. But what if the patient simply said, no, it's fine?
Well, they could not be translating the correct stuff to the patient.
Very good. If we can't speak that patient's language, we don't know that the person who's translating is accurately saying what we are trying to communicate. So the patient may actually be consenting to something that is not what we even said, or not what the surgeon even said. Right? And then the last part of that is that head-to-toe exam. And remember, that head-to-toe exam is where we gather that objective data as well as subjective data, focusing primarily on the acute concern, but also on those body systems at greatest risk based on the procedure we do. So cardiac, respiratory, neuro, renal, etc. And then the last part of our assessment is a nutritional assessment. Because the body does not heal without receiving what it needs from its environment, we need to know what this person is capable of doing during that post-op period. So we need to assess their general appearance, looking at their hair, their skin, their body size and shape. We need to measure what? Height and weight, yes. So that we can calculate the BMI and so that we can see where they stand within that ideal weight range for their height. So we can use the rule of 5 and rule of 6 like we do in simulation, and then we can calculate the BMI as well. Remember, height and weight is very significant when it comes to some of the post-op meds as well as the intraoperative meds. Anesthesia is sometimes prescribed medication for that patient's weight, especially pediatric patients. We also need to identify factors that might influence that person's nutrition. So do they have teeth? Or if they have dentures, do they have the dentures with them? Or are they ill-fitting? Or do they create sores if the patient doesn't choose to wear them? What are the financial resources available for them, especially after the cost of the procedure? What is their overall health and functional limitations? Are they able to provide for their nutritional needs, or will we need to refer them to Meals on Wheels or someone to assist them? Obesity presents a nutritional concern. We often don't think of obesity as being a nutrition problem, but it is. Sometimes you'll see it in textbooks as an overnutrition, and then the other one is undernutrition. Obesity, when it comes to surgery, increases the technical difficulty, especially if it's an abdominal procedure And it can increase the post-op infections as well as the risk for a hernia, dehiscence, or evisceration. We'll talk about what each of those are here in a little while. But basically, adipose tissue is not very vascular. As a result, it doesn't have a good blood supply for healing. It also increases pulmonary complications. We talked about that. We talked about how the person's own weight, their own abdomen can sometimes interfere diaphragmatic expansion during post-op time. We need to atelectasis and pneumonia development. And then lastly, it makes mobility difficult during the post-op period. It's easier to get a patient up and about when their own body is very easily able to lift itself. When that person struggles to lift their own body weight, it becomes a very big challenge for the staff as well. And then there are some lab tests that we can look at during a pre-op time to determine whether their nutritional concerns are acute or chronic in nature. So remember that each of those reflect protein nutrition. Okay, so if the person's albumin is normal, it indicates that they've had adequate protein intake for some significant length of time. However, sometimes our patients have been very sick for several days. And so pre-albumin gives us a hint that even though they might have ongoing good nutrition over the last few days while they've been so sick, it has not been adequate. And so the pre-albumin is the more acute one of those two numbers. So it indicates that we've got an issue here that may make it very difficult for the body to create new tissue during the post-op time. And so that will influence what the physician does nutritionally during that post-op time as well. Okay, I'm gonna pause right there. Are there any questions up to this point? That is our pre-op assessment. Obviously, that looks pretty in-depth. Recognize that that does not mean that we do that all in 15 minutes. That they will from the call and have a surgery in the same day center. Many of these things can be gathered in the clinic. Sometimes they're used in an online form. The patient fills out some of that information. And sometimes it is a telephone call from the perioperative prior to arrival. Any questions?
Can you have him turn the Zoom mic on again? Mr. Bear?
Yes, go ahead.
Did you get the student mic off?
Oh, no. Thank you.
Sorry.
You know, I could solve that problem and just not let the Stillwater students ever talk.
Yeah, I've often thought about doing the same thing with the students, but.
Oh, no, wait, I've got a Stillwater student has a question. I'm gonna have to turn the mic back on. So, okay, go ahead.
On your pre-op assessment slide, the summary one, the diagnostic and lab is on there. So is that, or you haven't done that, so is that not included in that, or it is?
Oh, very good. The student pointed out to that the diagnostic and lab is also part of our gathering data for the pre-op time. And she's correct. So that next slide on top 199 is really part of that pre-op, and I forgot that I had linked it to you. So thank you for doing that. And then you make the turn back. All right. So we're going to switch over now and talk just briefly about the general types of things we might use to prepare a patient for surgery as far as diagnostic and lab. Chest x-ray, if a client is going to receive general anesthesia, so if they're going to be intubated and receive a gaseous form of anesthesia, or if they're going to receive IV sedation to the point that they are going to be unresponsive and will no longer have a gag reflex, they will often be intubated. For those people, we get a chest x-ray to make sure there's nothing ongoing with that person to begin with. And then obviously there are lots of orthopedic surgeries that we need specific x-rays for those specific procedures. So a fractured arm would need an arm x-ray, a fractured foot, etc. Okay? CT scans, MRI, or nuclear medicine, they're used primarily to diagnose those soft tissue problems. Okay, so sometimes that's trauma, sometimes that's malignancy, but we're looking at things that x-rays don't really show up as well. X-rays will often change the thickness or the color on the screen, but you really can't tell what kind of tissue it is. It's an abnormal thing. And the CT, MRI, and nuclear medicine, especially if we use contrast, will give the surgeon a much better look at things. Recognize that some of these are used during pre-op, but some are used during the intraoperative time as well to help identify locations of things as the surgeon is doing the procedure. An EKG or ECG, those are both the same. One's the Old English, one's the Americanized version, if you will. It identifies the baseline electrical activity or the baseline cardiac rhythm of that client. It helps us to know whether they have what we call a normal sinus rhythm that we talked about in the fall, or whether they already have an abnormal rhythm. Remember, an abnormal rhythm will compromise their cardiac output. And once we put that heart under anesthesia, it may be severely compromised. And then we also want to use an ECG to rule out any acute problems, like is the patient experiencing an MI at the moment? The other lab that we need to know, because we need to identify their renal function, is we may have the client urinate for us, and we'll catch a clean catch sample so that we can identify if there's any acute problems like an infection or a chronic problem like renal failure where the urine is not concentrated or it's overly concentrated. Okay, so we need to identify those things before we start giving them IV fluids and medication or even contrast dye for their procedure. And then I've listed some broad categories or broad areas of lab and blood work that you will often see for virtually every major procedure. So remember I said separate major and minor procedures. CBC, I think we're at trunk wall. What's the two things we're trying to identify with the CEC? Two primary problems. Infection and anemia, that is correct, good. Kidney function, we're looking at their BUN and creatinine to make sure that they're able to get rid of the waste products of metabolism. Glucose, we talked about in the diabetes lecture. Remember that hyperglycemia makes it very difficult for tissues to heal, and hypoglycemia alters a person's level of consciousness, and so they can appear to have a delirium when it's really a hypoglycemic event. Electrolytes, we talked about this in the fall. We primarily focused on potassium, but all of the electrolytes can play a factor in this pre-op time. And so when we find a discrepancy in electrolytes, those need to be reported to the physician because the surgery may be postponed until those are corrected. A type and cross match or a type and screen. You can change that to type and screen or put it out in parentheses. A type and screen simply means that we identify what the patient's blood is and make sure that we have something in the lab that could be cross-matched if we needed to. If it's a major procedure where the threat of blood loss is significant, the physician or the surgeon will often tell us to type and cross-match, which means we already confirm that that unit of blood is compatible with the patient. So it's ready to transfuse in a matter of minutes if we needed to. And typically the surgeon will specify whether it's a type and cross or type and screen, and he'll specify if it's a cross match, how many units, based on what we call the estimated blood loss of that procedure. Okay, how much blood loss does the average person lose? Okay, and then there might be some client-specific tests. So the patient might be hypo or hyperthyroid, so we need to know where they stand before we take them